The heartbeat depends on a precisely coordinated electrical system. When that system becomes unstable, the result can be a cardiac arrhythmia. Antiarrhythmic drugs aim to restore stability, but they do so by modifying the very electrical processes that keep the heart beating normally. That makes them powerful, but also potentially dangerous. In this video, we'll take a broad, integrated look at antiarrhythmic drugs, covering all four major classes. We'll focus on their basic mechanisms, key drugs and clinical uses, without going into the detailed electrophysiology that fully explains their actions. If you are looking for greater depth, you can find separate videos on each individual drug class in the Heart Pharmacology lecture playlist. To understand how antiarrhythmic drugs work, it helps to start with the cardiac action potential. In ventricular muscle, the rapid upstroke of the action potential, known as phase 0, is driven by sodium influx and determines how quickly electrical impulses propagate through the heart. The action potential peaks when sodium influx ends, and partial repolarisation follows in phase 1. Phase 2, the action potential plateau, reflects a balance between the inward flux of calcium ions and efflux of potassium ions, while final repolarisation, phase 3, is dominated by potassium efflux. In this video, we'll use the action potential as a framework rather than exploring it in detail. A full explanation of how ion channels generate the action potential is covered in a separate video, which you may want to review if you're less familiar with the underlying electrophysiology. Many arrhythmias arise when these processes are altered, either through abnormal impulse formation, impaired conduction, or changes in refractoriness. Antiarrhythmic drugs target specific parts of this waveform to reduce the likelihood that arrhythmias can occur. Most antiarrhythmic drugs are organised using the Vaughan Williams classification, introduced in the early 1970s. This system groups drugs according to their primary effect on the cardiac action potential. Class 1 drugs block sodium channels, slowing the rapid upstroke of the action potential and slowing conduction. Class 2 drugs are beta blockers, which reduce sympathetic influences on the heart rather than acting directly on ion channels. Class 3 drugs block potassium channels and delay repolarisation. Class 4 drugs block L-type calcium channels and primarily affect the atrioventricular node. While this classification provides a useful framework, it's important to remember that many drugs have multiple actions and don't fit neatly into a single category. Class 1 antiarrhythmic drugs block fast sodium channels in cardiac muscle. By doing so, they reduce the rate of rise of the action potential upstroke, slowing conduction through the myocardium. However, these drugs vary in both the strength of sodium channel block and their selectivity for different channel states. Class 1 drugs are traditionally subdivided into 3 groups: Class 1A, Class 1B, and Class 1C. Class 1A drugs, such as quinidine, produce a moderate degree of sodium channel block by binding to channels in the open or inactivated states. As a result, they slow the action potential upstroke and conduction. In addition, they prolong the action potential because they are relatively non-selective and also block potassium channels that contribute to phase 3 repolarisation. Class 1B drugs including lidocaine, have weaker effects on the upstroke, but tend to shorten the action potential, particularly in depolarized or ischemic tissue. That is because they preferentially block sodium channels only after they have inactivated. As a result, they have little effect during the upstroke, with block accumulating later in the action potential and suppressing late sodium influx that would otherwise oppose repolarization. Class 1C drugs, such as flecainide, produce strong suppression of sodium current by binding to channels in any kinetic state. This leads to marked slowing of the upstroke and conduction, with relatively little effect on action potential duration at therapeutic doses. Clinically, class 1 drugs are used to treat both atrial and ventricular arrhythmias, but their ability to slow conduction also means they can promote re-entry under certain conditions. As a result, their use requires careful patient selection. Class 2 antiarrhythmic drugs are beta-adrenergic receptor blockers. Common examples include metoprolol, propranolol, and atenolol. Rather than acting directly on ion channels, they reduce sympathetic stimulation of the heart. Sympathetic activity involves the neurotransmitter noradrenaline released from sympathetic nerve terminals and the hormone adrenaline released from the adrenal medulla. Noradrenaline and adrenaline stimulate beta-1 adrenergic receptors, particularly in the sinoatrial and atrioventricular nodes. This increases the rate of rise of the nodal action potential upstroke, enhancing spontaneous firing in the sinoatrial node, known as automaticity, and accelerating conduction through the atrioventricular node. Blocking these receptors therefore reduces automaticity in the sinoatrial node and slows atrioventricular conduction. Clinically, beta blockers are widely used for rate control in atrial fibrillation, suppression of stress or exercise-induced arrhythmias, and prevention of sudden arrhythmic death after myocardial infarction. Their antiarrhythmic effects largely arise from modifying the context in which electrical activity occurs rather than directly altering the action potential waveform itself. Class 3 antiarrhythmic drugs act primarily by blocking potassium currents responsible for repolarization. Important drugs in this class include amiodarone, sotalol, dofetilide, and ibutylide. By delaying phase 3 of the action potential, these drugs prolong repolarization and increase the effective refractory period. This makes it harder for re-entrant circuits to persist. Multiple potassium channel currents contribute to repolarization, including the fast delayed rectifier, IKR, the slow delayed rectifier, IKS, and the inward rectifier, IK1. This redundancy means that when one channel is blocked, others may partly compensate, a concept known as repolarization reserve. The effect on this reserve ultimately determines the drug's impact. Although all class 3 drugs prolong the action potential, they differ markedly in how they interact with repolarization reserve. Drugs that predominantly block a single potassium current, such as the selective IKR blocker dofetilide, may be highly effective but carry a higher risk of pro-arrhythmia. Others, such as amiodarone, block multiple ion channels and tend to produce more stable electrophysiological effects across a range of conditions. Some class 3 drugs also have additional class actions. For example, sotalol blocks IKR, but also acts as a beta-adrenergic receptor blocker, which reduces sympathetic drive, limits excessive action potential prolongation, and helps protect against pro-arrhythmic effects. These differences explain why drugs within this class are not interchangeable in clinical practice. Clinically, class 3 antiarrhythmic drugs are used to maintain sinus rhythm in atrial fibrillation or flutter, to convert atrial arrhythmias to sinus rhythm, and to treat life-threatening ventricular arrhythmias. Their use requires careful attention to QT prolongation and the risk of torsade de pointes on the ECG, particularly with drugs that selectively block IKR. Class 4 antiarrhythmic drugs block L-type calcium channels. The main drugs in this class are verapamil and diltiazem. Their effects are most pronounced in nodal tissue, where calcium currents drive the upstroke of the action potential. By reducing calcium entry, these drugs slow the upstroke and prolong the pacemaker potential between action potentials. As a result, action potentials occur less frequently. That reduces automaticity in the sinoatrial node and slows conduction through the atrioventricular node. Clinically, they are used primarily for rate control in supraventricular arrhythmias, including atrial fibrillation and atrial flutter. In clinical practice, selecting an antiarrhythmic drug involves balancing efficacy against safety. Rate control strategies aim to slow the ventricular rate to a safe range without necessarily restoring normal rhythm. They commonly rely on class 2 or class 4 drugs. Rhythm control aims to restore and maintain sinus rhythm, the normal cardiac rhythm generated by the sinoatrial node. In this setting, class 1 or class 3 agents may be used. The choice of drug is influenced by the type of arrhythmia, the presence of underlying heart disease, autonomic tone, and the risk of proarrhythmia. Understanding the basic electrophysiological targets of each class helps explain why certain drugs are preferred in specific settings. To summarize, antiarrhythmic drugs modify cardiac electrical activity by altering conduction, automaticity, or refractoriness. The Vaughan Williams classification links these drugs to specific electrophysiological mechanisms, but drugs within a class can behave very differently. Appreciating how each class interacts with cardiac electrophysiology helps guide safe and effective clinical use. For a deeper understanding of each class, you can explore the individual videos linked in the description.